Hi, this is JV Villa, and I'm going to report about gastric cancer. So for the contents of the video, we'll start about the definition, then risk factors, the types, the pathophysiology, and then the signs and symptoms. And next are the assessment and diagnostics or laboratory tests, and then the management, which consists of medical and surgical and nursing management, and lastly is for complications. Cancer starts when cells in the body begin to grow out of control. Cells in nearly any part of the body can become cancer and can then spread to other areas of the body. Stomach cancer, or also called gastric cancer, begins when cells in the stomach start to grow out of control. It is an abnormal growth of cells that begins in the stomach. Stomach cancers tend to develop slowly over many years, and before a true cancer develops, precancerous changes often occur in the inner lining or mucosa of the stomach. These early changes rarely cause symptoms, so they often go undetected. Worldwide, gastric cancer is the fifth most common cancer diagnosis, with the highest incidence in Eastern Asia, Republic of Korea, Mongolia, and Japan. So next are the risk factors. Diet appears to be a significant risk factor for the development of gastric cancer. A diet high in smoked, salted, or pickled foods and low in fruits and vegetables may increase the risk of gastric cancer. Next is H. pylori infection. It is a major risk factor for the development of gastric cancer. Next is age. Stomach cancer is the most common around the age of 60. It's rare under the age of 40. Next is gender. Men are around twice as likely to develop stomach cancer as women. Other factors related to the incidence of gastric cancer include chronic inflammation of the stomach or gastritis, pernicious anemia, smoking, obesity, achlorhydria, gastric ulcers, previous partial gastrectomy, which is more than 20 years ago, and genetics. And for the inherited cancer predisposition syndromes associated with increased risk of developing gastric cancers include hereditary diffuse gastric cancer, Lynch syndrome, juvenile polyposis syndrome, familial adenomatosis polyposis, and Peutz-Jeghers syndrome. And now let us move on to the types of gastric cancer. Adenocarcinomas. Most cancers of the stomach, about 90 to 95%, are adenocarcinomas. These cancers develop from the gland cells in the innermost lining of the stomach or the mucosa. There are two main types of stomach adenocarcinomas. First is intestinal and next is diffuse. For the intestinal type tends to have a slightly better prognosis or outlook. The cancer cells are more likely to have certain gene changes that might allow for treatment with targeted drug therapy. Next is the diffuse type. It tends to grow and spread more quickly. It is less common than the intestinal type, and it tends to be harder to treat. Other types of cancer that can start in the stomach include first, lymphoma. Lymphoma generally affects the immune system of an individual. In some cases, this type of cancer develops on the walls of the stomach. Next is gastrointestinal stromal tumor. It is a rare form of stomach cancer which starts in the interstitial cells of Kegel in the stomach. Here, some of the cells of a tumor are benign while others are malignant. Next is carcinoid tumor. This type of stomach cancer develops in the hormone-making cells of the stomach, and it is also known as gastrointestinal carcinoid tumors. The good thing about this cancer is it generally does not spread to the other organs. Other types of cancer such as squamous cell carcinomas, small cell sarcomas, and leiomyosarcomas can also start in the stomach, but these cancers are very rare. And now let's move on to the pathophysiology of gastric cancer. Its etiology is unknown. For the precipitating factors, it includes diet or nutrition, which is high fat, low fiber, undercooked or charred foods, stress, bowel habits, and lifestyle, which includes smoking and alcoholism. For the predisposing factors, it includes age, which is 40 years old and above, heredity, environment, which is exposure to carcinogens, gender, previous gastric, colon, and rectal cancer. These affects the normal cells, which result to the mutation in a DNA mismatch repair genes. This could have a negative effect on DNA repair, and these mutated cell multiplies and results to uncontrolled proliferation. Affected normal cells, which also results to proctooncogenesis, and the activations of oncogenes, and then the tumor suppressor deactivates. If it deactivates, cells grow and divide quickly, and the DNA repair genes inactivates, which causes cancer cell division and proliferation. And this could also result to polyposis collagen inactivation, which permits unchecked cellular replication, and then cell division is increased. This could also lead to cancer cells undergoing further mutation and activation of oncogenes, which prevents apoptosis, which increases the lifespan of affected cells. It replicates just like normal cells, and the increased number of malignant cells. This invades the epithelia of the GIT, which alters the genetic makeup of the epithelium, lateral and downward spread of abnormal cells, and it replaces normal cells. It also transforms stem cell, and these altered stem cell replicates and results to adenoma. This extends to the adjacent cells, which results to adenocarcinoma. It extends downwards to small intestine, anus, and rectum, which results to anorectal mass and affects adjacent structures, which causes lymphatic spread. It also obstructs passageways because of mass or tumor, which then leads to tumor bleeding. It invades or compresses nerves, which results to back or pelvic pain, and results to bowel obstruction, which causes abdominal pain, and changes in bowel habits, loss or decreased bowel movement, retention of fecal matter, and results to sepsis. So now let us move on to the signs and symptoms. Symptoms of early stage disease may include pain that is relieved by antacids, resembling those of benign ulcers, and are seldom definitive. Symptoms of advanced disease are similar to those of peptic ulcer disease, such as dyspepsia or indigestion, early satiety, weight loss, abdominal pain just above the umbilicus, loss or decrease in appetite, bloating after meals, and nausea or vomiting. Fatigue often occurs as a result of the cancer itself, or blood loss from the lesion infiltrating the stomach or surrounding tissue. And next is for the assessment and diagnostics or laboratory. The physical examination is usually not helpful in detecting the cancer because most early gastric tumors are not palpable. Advanced gastric cancer may be palpable as a mass. Ascites and hepatomegaly or enlarged liver may be apparent if the cancer cells have metastatized to the liver. Palpable nodules around the umbilicus, called Sister Mary Joseph nodules, are a sign of a GI malignancy, usually a gastric cancer. For the test, esophagogastroduodenoscopy for biopsy and cytologic washings is the diagnostic study of choice, and a barium X-ray examination of the upper GI tract may also be performed. Endoscopic ultrasound is an important tool to assess tumor depth and any lymph node involvement. Next is computed tomography scanning. It completes the diagnostic studies, particularly to assess for surgical resectability of the tumor before surgery is scheduled. CT scans of the chest, abdomen, and pelvis are valuable in staging gastric cancer. A CBC may be used to evaluate for the presence of anemia. Assessment of tumor markers, blood analysis for antigens indicative of cancer, such as carcinoembryonic antigen or CEA, carbohydrate antigen, and CA50 are monitored to determine the effectiveness of the treatments. Tumor marker values are usually elevated in the presence of gastric cancer before treatment and decrease if the tumor is responding to the treatment. And now let us proceed for the management. First is a medical management. The treatment of gastric cancer is multimodal, often involving surgery, chemotherapy, targeted therapy, and radiation therapy. In general, the patient with a resectable tumor undergoes a surgical procedure to remove the tumor and appropriate lymph nodes. If the tumor can be removed while it is still localized to the stomach, the patient may be cured. In patients with a tumor that is not surgically resectable or those with advanced disease, cure is less likely. Treatment may include surgery to control the cancer growth or for the palliation of symptoms, chemotherapy, targeted therapy, and radiation therapy. So next are the surgical management. A total gastrectomy may be performed for a resectable cancer in the mid-portion or body of the stomach. The entire stomach is removed along with the duodenum, the lower portion of the esophagus, supporting mesentery and lymph nodes. Reconstruction of the GI tract is performed by anastomosing the end of the jejunum to the end of the esophagus, a procedure called an esophagojejunostomy. A radical, partial, or subtotal gastrectomy is performed for a resectable tumor in the middle and distal portions of the stomach. A Bilirubin 1 or a Bilirubin 2 operation is performed. The Bilirubin 1 involves a limited resection and offers a lower cure rate than the Bilirubin 2. The Bilirubin 2 procedure is a wider resection that involves removing approximately 75% of the stomach and decreases the possibility of lymph node spread or metastatic recurrence. A proximal, partial, or subtotal gastrectomy may be performed for a resectable tumor located in the proximal portion of the stomach or cardia. A total gastrectomy or an esophagogastrectomy is usually performed in place of this procedure to achieve a more extensive resection. Surgery may be also required to treat common complications of advanced gastric cancer, which may include gastric outlet obstruction, bleeding, and severe pain. Gastric perforation is an emergency situation requiring surgical intervention. And lastly is gastric resection. It is maybe the most effective palliative procedure for advanced gastric cancer. Palliative procedures such as gastric or esophageal bypass gastronomy or jejunostomy may be temporarily alleviate symptoms such as nausea and vomiting. Palliative rather than radical surgery may be performed if there is metastasis to other vital organs such as the liver or to achieve a better quality of life. And now we move on to the nursing management. First is to monitor nutritional intake and weigh patient regularly. Next is to monitor CBC and serum vitamin B12 levels to detect anemia, and monitor albumin and pre-albumin levels to determine if protein supplementation is needed. Next is to provide comfort measures and administer analgesics as ordered. Next is to frequently turn the patient and encourage deep breathing to prevent pulmonary complications, to protect skin, and to promote comfort. Next is to maintain nasogastric suction to remove fluids and gas in the stomach and prevent painful distension. Next is to provide oral care to prevent dryness and ulceration. Keep the patient nothing by mouth as directed to promote gastric wound healing. Administer parenteral nutrition if ordered. Next is when nasogastric drainage has decreased and bowel sounds have returned, begin oral fluids and progress slowly. Next is to avoid giving the patient high carbohydrate foods and fluids with meals, which may trigger dumping syndrome because of excessively rapid emptying of gastric contents. Next is to administer protein and vitamin supplements to foster wound repair and tissue building. Next is to eat small, frequent meals rather than 3 large meals. Next is to reduce fluids with meals but take them between meals. Next is to stress the importance of long-term vitamin B12 injections after gastrectomy to prevent surgically induced pernicious anemia. And lastly is to encourage follow-up visits with the healthcare provider and routine blood studies and other testing to detect complications or recurrence. And lastly for the complication. If the stomach cancer progresses to advanced stages, then it may lead to many complications like gastrointestinal bleeding, gastric perforation, and small bowel obstruction.
Hello everyone, I am Clarice Dela Peña, and now I will be reporting about the colorectal cancer. So this is another gastrointestinal disorder followed by the gastric cancer reported by J.V. Villa. So the contents. First, we will be talking about colorectal cancer. In definition, cancer that begins in the colon is called colon cancer, while cancer in the rectum is known as rectal cancer. So cancers that affect either of these organs may be called the colorectal cancer combined. Now we have parts affected with this cancer. First is colon and next is rectum. So the colon is approximately 5 to 6 foot long that connects the small intestine to the rectum. The colon, which along with the rectum, is called the large intestine. So these are responsible for the moving and processing and digesting of food across the body down towards the rectum, where it exits the body as a stool. So we have different parts of the colon: ascending colon, transverse descending, the sigmoid, and the rectum, where it is 5 to 6 inches. Its purpose is to store the unit and hold the stool until defecation occurs. Next is the risk factors. Includes the following. First, age over 50. So this disease is common in people older than 50, and the chance of getting colorectal cancer goes up with each decade past age 40. Next is being African American. So ethnicity plays an important factor in this disease. The male gender. So a higher incidence of colorectal cancer is found in males compared to females. So this increased vulnerability of men may be due to the number of biological and gender-related factors. Family history or colorectal cancer. So those who have first-degree relative that have this disease are at increased risk. Next is history of other cancers include the uterine and ovarian cancer. So people with personal history of colorectal cancer previously or a diagnosis of ovarian cancer or uterine cancer are more likely to develop colorectal cancer. Next is inflammation bowel disease or the IBD. This includes the Crohn's disease and the ulcerative colitis. So IBD is a condition in which the colon is inflamed over a long period of time. So if left untreated, it will develop in dysplasia. So the cells in the lining of the colon or rectum looks abnormal but are not cancer cells. So they can change into cancer over time. So dapat dili jud magkumpiyansa. Next is obesity. So obesity can change the function of essential hormones like insulin and leptin. Next is polyps. So these grows in the inner walls of the colon or rectum that aren't cancer, but they can lead to cancer any period or any time. They're fairly common in people over age 50. One type of polyp called adenoma makes colorectal cancer more likely. So adenomas are the first step toward colon or rectal cancer. Poor nutrition. So these are effective in those who consumes a lot of red meat and cholesterol, also consumes only little fiber or doesn't eat fresh vegetables or fruits. Next is alcohol and cigarette smoking. Genetic syndromes. So first we have the FAP or the classic FAP. So this is a genetic condition. This is diagnosed when a person develops more than 100 adenomatous colon polyps. So adenomatous polyps is an area where normal cells that line the inside of a person's colon from a mass of the inside of the intestinal tract. Next, we have the Gardner syndrome. So this is a type of FAP that is also non-cancer tumors. Next is the HNPCC or Lynch syndrome. So the cancers linked into this syndrome tend to develop when people are relatively young. So people with Lynch disease or syndrome can have polyps, but they tend to only have a few. So in the lifetime risk of colorectal cancer in people with this condition may be as high as 50%, but it also depends on which gene is affected. Peutz-Jeghers syndrome. So the people with this inherited condition tend to have freckles around the mouth and sometimes in their hands and feet. And a special type of polyp called hamartomas in their digestive tracts. So these peoples are at a much higher risk of colorectal cancer as well as other cancers such as the breast, ovary, and pancreas. Now let's talk about the different types of colorectal cancer. We have four different types of cancers in the colon and rectum. First, we have the GISTs, or these are uncommon cancers that start in special cells in the wall of the GI tract that are called the interstitial cells of Cajal. Next, we have the carcinoid tumors. These are also called the neuroendocrine tumors. These are mostly slow growing, but some are not and can possibly spread on other parts of the body. Next, we have lymphoma. These are form of cancers affecting a type of white blood cell called the lymphocyte. So, as with all forms of cancer, lymphoma involves the abnormal growth of cells, as cancerous lymphocytes freely circulate through the bloodstream. So they can cause the formation of tumors in parts of the lymphatic system. And last type, we have sarcomas, the cancers of connective tissue cells. For stages of cancer, stage 0, also known as carcinoma in situ, the disease remains within the lining of the colon or rectum. So it is not, it is the precancerous stage and are not cancers yet. For stage 1, they have grown into the wall of the intestines but have not spread beyond its muscular coat or into the closed lymph nodes. For stage 2, this is divided into three smaller stages. Stage 2A, the cancer has spread already through the wall of the colon. For stage 2B, the colorectal cancer has penetrated beyond the muscular layers of the large intestine. And by stage 2C, the cancer has even spread into adjacent tissues. However, in all of these stage 2 lesions, the cancer has not yet reached the lymph nodes. Next is stage 3. So this is considered as an advanced stage of cancer as the disease has spread already to the lymph nodes. So there are three smaller stages, which includes stage 3A. The cancer has moved beyond the colon wall and spread to 1 to 3 lymph nodes, or a very early lesion in the colon wall that has spread to 4 to 6 lymph nodes. Next, the second stage, 3B, more lymph nodes are affected and more advanced lesions. Next is stage 3C. The cancer continues to spread to nearby lymph nodes and the impacts more adjacent tissues or organs in the abdomen. And lastly, we have stage 4. So in here, the disease already has spread to distant organs such as the liver, the lungs, or ovaries. So this is divided into three stages also. Stage 4A means that characterized by cancer has spread to an organ and lymph nodes that are farther from the colon. In stage 4B, cancer has moved to more than one distant organ and more lymph nodes. And lastly, stage 4C, the cancer has impacted not only the distant organs and lymph nodes, but also the tissues of the abdomen. Next, we'll proceed to the pathophysiology of colorectal cancer. So colorectal cancer begins when healthy cells in the lining of the colon and the rectum change and grow out of control, forming a mass called a tumor. So in this diagram, it will show the sequence of molecular and genetic events leading to transformation from adenomatous polyps to overt malignancy. So first we'll have the normal colonic epithelial cell, or what we call as the normal colon cell. So the early event is a mutation of the APC, or what we call as the adenomatous polypsis gene. So the protein encoded by the APC is important in the activation of the oncogene C-mysin and cyclin D1, which drives the progression to malignant phenotype. Now, when this gene has lost its function due to the mutation, it would lead to the increased cell growth. So that is why there is hyperproliferative cell, or the hyperproliferative epithelial aberrant cryptic foci. This would lead to initial adenoma. So another important gene in colon carcinogenesis includes the KRAS oncogene. So the KRAS genes gets mutated. This is an apoptotic gene that in this result of mutation, these genes are no longer functional. So those apoptotic genes which are helping in the apoptosis of the normal cell, after some type of division are getting distorted, and as a result, the initial adenomas will become immortal. So the next process would lead to the intermediate adenoma. So this is it. After initial adenoma, intermediate adenoma. So after that, the DCC now, or the DCC gene gets mutated also. Then again, the P53. So these genes are controlling the growth of the cell as they are called tumor suppressor genes. So because these genes gets lost in its function, then we'll have that the cells will no longer control the growth, especially in the adenoma, in the late adenoma. They will proliferate, divide, and grow more. So this would lead to providing adenomas, the gain of immortality. So now, none of the cell's machinery will stop their growth, so they become carcinomas. Now that it grows to become carcinoma, it will gain a lot of functionalities such as loss of contact inhibition. So because of this, they will have time for progression. So now the mutation results in a so-called high-frequency microsatellite instability. So this will, in addition for the mutation, epigenetic events such as an abnormal DNA methylation can also cause silence of the tumor suppressor genes. Um, this will compromise the genetic balance and ultimately leads to malignant transformation and eventually metastasis. So the cancer cells produce extracellular vesicles, principally the microvesicles and exosomes. So they can promote the growth, the survival, and the invasiveness and metastatic activity of the tumors. Next is the signs and symptoms of this disease. So the symptoms are determined by the location of the tumor, the stage of the disease, and the function of the affected intestinal segment. The most common presenting symptom would be the change in bowel habits. Also unexplained anemia, anorexia, fatigue. So for the right-sided lesions, we have the dull abdominal pain and melena, and for the left-sided lesions, blood or bright red or very dark stool, in diarrhea, constipation, and feeling of bowels don't fully empty, stools that are narrower than usual, weight loss for no known reason, vomiting, and frequent gas pain, bloating, fullness, or cramps. Next, diagnostic tests. So firstly, we'll have blood tests. Colorectal cancers often bleeds into the large intestine or rectum, so people with this disease may become anemic. So we'll need blood tests. First is CBC. So this can show anemia. Some people with colorectal cancer become anemic because the tumor has been bleeding for a long time. Next, we'll have the liver enzymes. This test is a blood test to check for the liver function because colorectal cancer can spread to the liver. Next, we'll have tumor markers. So colorectal cancer cells sometimes make substances called tumor markers that can be found in the blood. So the most common tumor marker is called the carcinoembryonic antigen. Next are the screening tests. So doctors would look in colonoscopy using a colonoscope. It is a thin, flexible, lighted tube with a small video camera in the end. Next, biopsy. So this is a removal of a small amount of tissue for examination under microscope. And the next is proctoscopy. So this is the test that may be done if rectal cancer is suspected. Imaging studies. So in imaging studies, we have CT scan, the MRI, the ultrasounds, which is composed of other abdominal, endorectal and intraoperative, then chest X-ray, and PET scan. Next is the management. So for medical management, the treatment options depend on several factors, including the type and stage of cancer, possible side effects, and the patient's preference and overall health. So we'll have radiation therapy. Then we'll also have medications that will be prescribed by the physicians. So we'll have chemotherapy medications, targeted therapy medications. These are the following. Epidermal growth factor receptor inhibitors, tumor agnostic treatment, and immunotherapy medications. Next is surgical management. So this is the most common treatment for colorectal cancer. It can be for curative or palliative care. So segmental resections with anastomosis, abdominoperineal resection with permanent sigmoid colostomy, laparoscopic surgery. Colostomy for rectal cancer can be permanent or temporary. Construction of coloanal reservoir or colonic J pouch, then radiofrequency ablation or cryoablation. So preoperative, the patient should be prepared physically to develop stamina days prior surgery. Recommend diet high in calorie, protein, and carbohydrate. So a full, clear, liquid diet may be given for 24 to 48 hours before surgery to decrease the bulk. Then cleanse bowel with laxatives, maintain fluid volume balance, observe for signs of hypovolemia, assess hydration status, and then educate patient about information of post-operative care and provide emotional support to patient and family. Then intraoperative, anesthesia and analgesia. In the post-operative, pain management during immediate post-operative period, then monitor for complications. You assess the abdomen for returning peristalsis and initial stool characteristics, then maintain the nutrition of the patient. Frequent abdominal examination of the dressing, then inspect the vital signs, check for indication of infection. Lastly is the complications brought about by colorectal cancer. First, we have the cancer that spreads. So colorectal cancer mainly affects the large intestines. So in severe cases, the cancer spreads to other tissues and organs nearby, such as the small intestine. Next, we have bowel obstruction, so blockage in the colon. Next is development of secondary primary colorectal cancer. Then we also have surgical complications. So superficial wound infections are most common complications of colorectal surgery. Next is jaundice, because the colon cancer spreads to the liver and it is a common site of metastasis. And lastly, we have the iron deficiency anemia. So due to microscopic bleeding from a tumor, iron deficiency anemia may occur as the first sign of colon cancer. So we have reached the end of the slide. This is the end of our report. Thank you so much and God bless us all.